Half of people who have heart attacks have normal cholesterol. So suppressing cholesterol production with statins isn't necessarily reducing risk for all patients, and that is clear. So what are the other things that contribute to that? Well, it's actually plaque rupture that causes most heart attacks and strokes. And most heart attacks and strokes are caused by less than 50% occlusion, which means it's not the choking off of the vessel by long-term plaque accumulation and calcification of that plaque. It's actually that there's plaque there and it festers. It's like a pimple on the inside wall of the artery. So when we're assessing cardiovascular risk, we have to think beyond cholesterol, right? So yes, I want to know what somebody's Apo B is, or LDL particle number, because that's telling me how many bad particles are they making. I want to know the size of those particles. If they're big and fluffy, they're rolling off the artery wall rather than getting through. I want to be thinking about if they have endothelial dysfunction, because if they do, they have leaky arteries. So easier for that LDL particle to go in, start the plaque cascade. And then there's things that we can measure to see, well, is it likely that that plaque is inflamed and unstable? We can measure the oxidation level of LDL, so oxidized LDL. We can measure myeloperoxidase, which is an enzyme the white blood cells make that can contribute to unstable plaque. We can measure CRP, which is non-specific, but if it's high, it's telling us there's inflammation somewhere. We have to figure it out. It's usually coming from the gut, or coming because they're obese and they've got excess fat tissue, or they're not flossing, or they've got periodontal disease or something like that. So we have to figure that out. So there's a lot of different markers that we can look at to properly assess cardiovascular risk besides imaging.
Hey folks, welcome back to High Intensity Health Radio. It's Mike Mutzel here. I'm grateful and honored that you decided to tune back in. Today we're live with my friend Dr. Kathryn Retzler. She's the author of a wonderful book, Hormone Synergy. And today we're going to talk about heart disease, cognition, and how you can slow down your biological age. So Dr. Retzler, thank you so much for being here.
Thanks for having me. PPIs suppress nitric oxide production.
Wow.
That's why they increase heart attack, stroke, potentially kidney damage, and dementia risk. This isn't new data. Oh my God, I had a great case today with a patient about that. Like, she's been on a PPI for 10 years. She's osteopenic. She has carotid artery disease and increased IMT, which I told her also correlates with increased dementia risk. She's 60 years old. She thinks she's fine. She's hyperlipidemic and her blood sugar's high. She looks fine. She's a chef and she writes cookbooks.
Wow. And
she grows a lot of her own food. And she looks normal. But if you looked at her labs, her ADMA is off the charts. She's borderline hypertensive. She's not okay. And I told her, you're 60 years old. What we're doing today pays off in 10 years, right? And when we talked about all the contributing factors, I'm like, okay. And this is the beauty of natural medicine. You went on a PPI 10 years ago because and this was interesting how this happened. Her pulmonologist did a therapeutic trial of a PPI to see if her problem was GERD, contributing to asthma. The PPI took away her asthma because she was actually having reflux. So now I'm cured. It's a miracle.
Yeah.
Except for she didn't have an XEM deficiency. So now what's happened is she's been on that for 10 years. She has bone loss. She has carotid artery atherosclerosis and an increase in IMT, right? Depression. And I'm like, well, here's what happened. Now you have no hydrochloric acid. Oh, and her B12's low. You have nutrient deficiencies, especially minerals, which is how you ended up with bone loss. You may have an overgrowth of bacteria in your gut, which is why you have bloating. You may have leaky gut, which is causing endotoxemia, which is increasing your Apo B, which keeps going up, and your CRP, which keeps going up. And it's like, this is all related.
Right. Wow.
So, and we've had this conversation, are you ready today to talk about the cause? Yes. What does it entail? Well, it entails this. Well, I'm not sure I can do that. I know.
Very interesting and very sad. People get psychologically dependent upon the PPIs for some reason, and I think that transition off of that becomes challenging with that. But let's dive into the details of that, Kath. Just for the listeners, I want them to understand that you wrote a great book called Hormone Synergy, and you also lecture to a lot of practitioners and educate them and help Body Logic, a bunch of traditional physicians, learn bioidentical hormones. So you've been doing this I consider you a pioneer, and I want to commend you for that, Kath.
Thank
but
you.
I want to pick your brain on aging, and I guess we can, kind of launch and pick apart this case that you just presented to us. You mentioned AMDA, right? Asymmetric dimethylarginine and so forth. These are like some biomarkers linked with cellular aging and cardiovascular disease, right? So let's kind of
Endothelial dysfunction.
tease that one out. I think that's big.
Well, the number one killer of Americans is cardiovascular disease. So that's why that's a big part of my practice is, preventive cardiology. And also what's good for the blood vessels in the heart is good for the brain and good for cancer prevention. So, it's all one disease, as Jeff Bland likes to say. But there's a lot of biomarkers that can be looked at. So half of people who have heart attacks have normal cholesterol. So suppressing cholesterol production with statins isn't necessarily reducing risk for all patients, and that is clear. So what are the other things that contribute to that? Well, it's actually plaque rupture that causes most heart attacks and strokes. And most heart attacks and strokes are caused by less than 50% occlusion, which means it's not the choking off of the vessel by long-term plaque accumulation and calcification of that plaque. It's actually that there's plaque there and it festers. It's like a pimple on the inside wall of the artery. So when we're assessing cardiovascular risk, we have to think beyond cholesterol, right? So yes, I want to know what somebody's Apo B is, or LDL particle number, because that's telling me how many bad particles are they making. I want to know the size of those particles. If they're big and fluffy, they're rolling off the artery wall rather than getting through. I want to be thinking about if they have endothelial dysfunction, because if they do, they have leaky arteries. So easier for that LDL particle to go in, start the plaque cascade. And then there's things that we can measure to see, well, is it likely that that plaque is inflamed and unstable? We can measure the oxidation level of LDL, so oxidized LDL. We can measure myeloperoxidase, which is an enzyme the white blood cells make that can contribute to unstable plaque. We can measure CRP, which is nonspecific, but if it's high, it's telling us there's inflammation somewhere. We have to figure it out. It's usually coming from the gut or coming because they're obese and they've got excess fat tissue, or they're not flossing, or they've got periodontal disease or something like that. So we have to figure that out. So there's a lot of different markers that we can look at to properly assess cardiovascular risk besides imaging. So all my patients who are high in lipids and have increased risk are getting a CT, so I can see what their calcium score is, because if their calcium score is 0, it has excellent negative predictive value. So I can tell them the likelihood of you having a heart attack in the next 15 years is close to 0. There's meta-analyses that show that. So now we have some time to work on the underlying cause of your increased risk, right? So we don't have to be aggressive with our therapies. So they don't have to get 80 milligrams of Lipitor.
Right.
Or, looking at an IMT and carotid ultrasound, again, looking at the actual vessels to infer if they already have a disease process, or if we're trying to work, upstream, because that's the problem is, most medicine now is triage, right?
Right.
It's all sick care. It's not health care.
Yeah. Now, do you see this in the aging process? Like as people start to get into their late 40s and 50s, you start to see one physiologic manifestation of aging, this cardiovascular component, would you say, or is there?
Well, I do a lot more testing than just cardiovascular assessment.
Sure.
But I would say that it's the rare patient who comes in and is vibrant and optimally healthy at age 40 even. Wow. Yeah, so I try to inspire people to do something in their 30s if I have the opportunity, but definitely by their 40s. And, there's this interesting thing that happens, and I think it's because of just, this concept of functional reserve, which is our organs are really only made to last a certain amount of time, right? So you can only divide a cell so many times, or your liver can only work for so long, and your heart, etc. So every organ has a lifetime, right? So what we're trying to do is extend that functional reserve. That's what anti-aging medicine is. You can't stop aging or reverse it, but can you actually extend the health span, the time by which somebody starts declining? Well, nowadays people start declining in their 40s. Whereas we actually have the tools and the technology, and I have wonderful patients as examples who are vibrant and healthy and alive and are not suffering with chronic disease up until their 80s.
Wow.
So I don't know why more doctors don't promote that's possible. I guess, some of it has to do with where you're getting your continuing education dollars. It's a $700 billion a year industry worldwide, so drugs make money and drug companies educate doctors.
Right, so they're stuck in that model. And what's
Yeah.
really unique about all these tests that you mentioned, like endothelial dysfunction and AMDA and myeloperoxidase, I mean, if a traditional practitioner measures that, they're like, okay, well, how does that change my treatment? You know, I only have my toolbox is pretty small if one was practicing traditional medicine.
That's right.
Now, I want to get into all those details and stuff, but want to talk about the bigger picture here, because you mentioned that you're seeing a functional decline in people's vitality, really, starting at earlier and earlier age. And I think, again, the traditional model is, oh, they just need more hormones. Well, are you seeing let's talk about the bigger picture of the lifestyle. Obviously, hormones play a role, and that's a part of your practice, but there's multiple facets in that, kind of context in that therapy.
Yeah.
Are you seeing the hormones decline as a result, kind of as a symptom of disease processes, or are they causing the issue?
Well, that's a great question. I think it's both. You know, if a woman comes to me and she's in her mid-40s or young 40s and she's not sleeping, so now growth hormone is declining, but if she's not sleeping because she has hot flashes or because she's wide awake because she has no estrogen, well, then I've got to treat that. Because to tell her, well, you just need to sleep and you need to exercise when she's exhausted because she's not sleeping, so both are true. We're definitely seeing sperm counts go down and testosterone levels decline in men worldwide, unfortunately, at younger ages. I've been practicing 15 years, so I've actually seen men who are younger coming in. I don't know if that's just an artifact of more men call my office at younger ages because they want help, or if there are, men who are younger now who are hypogonadal. But the lifestyle factors definitely play a role in whether or not somebody can make optimal hormones. So the hormones are, I call it the icing on the cake. But, I've been doing this long enough now where I will honestly say, I think it's very hard to age well without hormones. They are the icing on the cake. Nearly all my patients are on hormones. I prefer they take care of all the diet and lifestyle at the same time. But I think it's very hard to be in your 60s and 70s not having done hormones and have a optimal brain and cardiovascular system and bones and energy level. I mean, we're, as Dan Bittner says, we're programmed for reproductive success, right?
Right.
So when our reproductive capacity is exceeded, we now are competing for resources, and we're just kind of meant to fall apart on schedule and get out of the food,
Interesting.
competition. So
yeah, what happens if someone doesn't take care of the lifestyle factors but jumps on the hormones? Can there be negative consequences?
Yeah. Well, I don't treat them. So I'm privileged enough now where I get to pick the patients I want to work with, and it's mainly because I want to be ethical, and I feel like it's potentially doing bad medicine to light a powder keg. So for example, you've got a guy with a pregnant man, with hot adipose tissue and insulin resistant and already having disease processes. I don't know that we know enough about adding hormones to that milieu, right? So unless he or she, same thing can happen for women, is willing to work on becoming vibrant and healthy, I don't work with them because I'm not sure that that's good medicine.
Because the aromatase activity in fat cells and all the other components is what you're referring to?
Yeah, and I think when, I'm not concerned about testosterone and cardiovascular risk because I think the data is heavily weighted on it being protective. But, the body is smarter than us. So when there's a disease process that's started, we call it disease. It's actually some level of homeostasis, right, that's going on. So, you're healthy, you're fit, you're exercising, you're eating well, your inflammation's low. That's the state at which your hormones would naturally be their highest when you're young of reproductive age. It makes sense to mimic that as you're aging if you're going to use a powerful substance like hormones. Hormones are found in parts per billion in the bloodstream. These are very powerful substances. They shouldn't just be thrown into like a toxic soup, right? Yeah. So that's my ethics. That's where I feel like I'm doing good medicine.
Is making sure the lifestyle bases are covered, so to speak.
And nutrition.
Nutritional.
Yeah, when I wrote my book, I came up with those 8 steps. The 8th step is hormones. The first 7 steps are things that anybody can do. And I think they're in some ways more important than the hormones. That's why I made that the 8th step. Unless, of course, somebody's hormones are so out of balance that, like I said, now they can't really do the other 7 steps.
Mm-hmm. Like if they've seen a practitioner that didn't address all those other factors, because I do get this question from women like, oh my gosh, I was on, biased for this from my traditional doctor, and now I'm all out of whack, I have thyroid issues and so forth. So that does come up when a practitioner, I guess, isn't as advanced and doesn't dive as deep as you do. There are some consequences. So I just wanted to address that.
Well, that's a really good point. I mean, every hormone impacts every other hormone. Mm-hmm. And when I teach, I have this big cascade of how hormones interact with one another. And so you've got to have that blueprint. Yeah. Physicians are supposed to be thinkers, right? We're not just like
computers.
Yeah, monkeys pushing buttons. So we have to think, like if I do this, if I put her on estrogen, then thyroid binding globulin will go up, potentially needing a thyroid adjustment. Or if somebody's really stressed, now perhaps they're not converting their T4 to T3, we have to look at that. So every hormone impacts every other hormone, and I don't just do one hormone. So if a woman comes to me and she just wants estrogen replacement, when would a woman ever have just estrogen in her body and no progesterone and no testosterone? So I make sure everything is imbalanced as much as possible because it just makes sense to do that.
Right.
And I think it's the safest way to do it too, actually.
Yeah. Looking at the body as a system.
Yeah.
More so.
Yeah.
I like that. There's controversy over different types of delivery systems. You just want to kind of finish up the hormone discussion a little bit.
Yeah.
I know you've had really good clinical success with pellets. You use creams and things. Everyone's individual, but what are your kind of thoughts to give a big picture overview of the different delivery methods?
Well, it depends on the hormone that you're talking about.
Yeah.
If you're talking about the sex steroids, because that's probably where you're getting questions about it, besides maybe the beastie bit type thyroid replacements. But for estrogen replacement therapy, I mainly use estradiol, which is the most potent estrogen. Bioidentical just means the same molecule that's made in the human body. That's what that means. There are pharmaceutical options, there are compounded options, but the most important thing to me is it the same molecule that the human body makes?
Yeah.
So I use the patch, the twice-a-week patch specifically. I'll use a troche, which goes through the buccal mucosa. Part of that gets swallowed, so there's considerations there. Might raise CRP, always making sure that they don't have increased clotting risk genetically. For estrogen replacement, I use vaginal a lot, vaginal delivery. Great delivery method for estrogen, especially if a woman has vaginal atrophy or, I don't know if this is too graphic, but
no, dryness, stuff like that.
Yeah, I mean, especially at first, because that's a good absorptive medium like our mouths without going through the liver. So vaginal delivery. I rarely use topical estrogens. They don't work very well. And, if you think about it, it's because you've got different absorbabilities, right? So the base matters, the surface area matters. So the amount of area you're covering, where you're applying the cream matters. It's just harder to dose and harder to get consistent results. I have women on it, but it's not, a common way of prescribing anymore. I use a lot of injections. The injections 100% absorb, so I don't have to wonder what they're getting. I have great results with injections. I use baby needles because I'm a baby. I hate needles. So I just teach women to do it themselves. I don't have women OD on estrogen. So I use a lot of different delivery methods. It's really what, I tell the patient what my experience is with these different methods, and then help them make a decision that makes sense to them. I do use pellets. I've been doing pellets now for 10 years out of the 15 years I've prescribing hormones. 10 years, maybe 11 years. I'd have to look at that. But I have great results with pellets. I've people coming from all over the country with pellets, but they're not right for everybody.
Wow.
You can't take them out, for example. So I make sure the person is really ready for a pellet.
Sure.
They're the right candidate. So really, to me, the best option is the one that works for the patient, although I would say there's some that are more effective and certainly easier to monitor than other options.
Mm-hmm. So you lay out the options and then look at each hormone that's out of balance and customize it, tailor it to that.
Yeah.
And that's what you're teaching to doctors. I know in October you have this great conference in Portland. You're going to talk to doctors about that. Is that one aspect of it then, or?
Yeah, that's a big part of it. I can't see very many patients anymore, and there's such a need. I mean, people are suffering, and this information can be streamlined. I feel like I've kind of piecemealed it over 15 years, and I'm also privileged that I have a husband that takes care of a lot of my daily needs, and so I can spend the time. I can actually read research as opposed to just listen to what people say. And so I feel privileged that I've been able to accumulate a certain amount of knowledge, but then also clinical experience. I mean, there's no shortcut for experience.
Right.
And there's a lot of people suffering, and I would like to help them. So I would like to train other doctors to help them, because
you can't see everyone yourself.
Yeah, I mean, Daniel does all the new patient intakes. I think we accept like 1 out of 20 or 30 patients who try to schedule. I cannot see more people.
Right.
And there's a lot of people who need help, and they deserve help. But right now, patent pharmaceuticals are pretty much all that the conventional docs are going to prescribe. It's not customized. The training needs to happen. Right. I've been to so many anti-aging conferences for the past 12 or 13 years, and nobody is really putting it all together, to me, that I've seen, in a streamlined approach for all the options, because everybody gets on their bandwagon. Right. I love this, or I love that, or and that's great if that's what their experience is in. But sometimes people will come to me and say, well, my doctor said this, that, or the other about pellets. I'm like, well, does your doctor do pellets? No. Okay, well, that's why your doctor has a bias. So I feel like I've used everything, and I would like to teach that, how to know what to do and how to treat safely, and then also the data. So, I mean, again, I'm privileged that I have somebody taking care of a lot of my background needs so that I can do what I love and also know the data. I think that is maybe a missing piece for a lot of practitioners, is that they don't really know the research. And so I want to streamline that. Be like, these are the major studies, and this is what you need to know. And also, provide references to patients, because they're smart.
Right.
And people, a lot of times, my doctor said this, that, or the other. Okay, well, let me show you where you can access this information on my website and read the abstract that I put there for you, because you're smart. So you can start accumulating your own information. So that's what I'm hoping to do with the training. That's
awesome. Yeah, I look forward to that and learning more about that. Over the last 5 or 6 years that I've known you and Daniel and stuff, I've seen you really dive deep into certain topics, and that's why it was kind of fun today to hopefully talk more about heart disease and then the brain and maybe the interconnected aspects there. Maybe we could finish off with heart disease and then kind of jump in the brain. And again, those biomarkers, you mentioned looking at LDL and HDL particle size and these myeloperoxidase. Which labs, because you're seeing a lot of patients, going to a lot of conferences, talking to the best of the best in this space, like Mark Houston, what labs do you recommend? I mean, if you were to give someone some bullet points here so that if they want to go to their practitioner to get a real true assessment.
Well, I can tell you what I order. I think the average patient might run into some resistance, understandably, and we can talk about that too, because unless a practitioner knows what to do with the information, he or she's not going to order the test, which makes sense.
Right.
But the basics of what I would order on a patient who I want to really assess their risk, and let's just say they're the average patient who's a little overweight, they have a family history, because almost everybody has somebody, right? So then I would run a lipid panel, and I like to see the particle size, and I like to see the particle number as opposed to just LDL cholesterol. So I'll run an Apo B, and then the size of the LDL particles, and then I'll run Apo A-I, which essentially is HDL particles. And I use Boston Heart for their HDL map, because it's actually giving you the alpha-1 and alpha-2 particles, so you can actually see what size HDL particles they are, inferring HDL functionality, which is really important, right? So if somebody could make a lot of HDL, but it doesn't work, it's not really helping the brain, and it's not really helping the blood vessels. So I'll run that. And then I'll run, CRP. Sometimes I run lipoprotein phospholipase A2. I used to run it a lot more. I'm suspicious about it. I think the assay may be inaccurate with transport across the country, and I won't even go into that, but I used to run that more. MPO, myeloperoxidase, fibrinogen. Occasionally I'll run TNF-alpha or something like that, or IL-6. Is this too much information,
no,
or
this is
what
awesome.
you wanted?
Cleveland Heart Labs for those
I don't use
tests?
Cleveland. I'll use Cleveland for oxidized LDL, but I use True Health and Boston, because they're wonderful and very low priced for my patients. And then I always run essential fatty acids, so I want to see what's their saturated fat, what's their trans fat, what's their EPA and DHA level. I always run that in addition to all their hormones and their thyroid and vitamin D.
That's fantastic. So there's interestingly some controversy over fasted versus postprandial lipid testing, and this is really talking more traditional, like
Yeah.
triglycerides and cholesterol. Do you encourage people to fast, or are you doing?
I always have them fast.
Okay.
Yeah, I know. I've heard that too. Like maybe it really doesn't matter. You know, if their triglycerides are 600,
Yeah.
it's not because they just ate, right?
Right.
And I always fast them because I'm also doing, I should have said blood sugar and hemoglobin A1C and insulin at a minimum. Sometimes I'm looking at adiponectin. Sometimes I'm looking at their, you know, other markers associated with blood sugar problems like leptin. But so I always have them fast.
Mm-hmm. Sure. I was curious about that.
Yeah.
I started to see that trend emerge in like 2010.
Yeah, because maybe it doesn't make that big of a deal. You know, if their LDL's over 190, it's probably genetic, and you just say, oh, well, they need a statin anyway. I think it depends on why you're treating, right?
Yeah. Interesting.
Might be interesting to do before and afters, but
yeah.
it gets expensive.
Okay, so we were emailing about TMAO, trimethylamine oxide, I believe, the gut bacteria-made metabolite that's cardiotoxic. And what's interesting is talk about where it comes from, and a quote-unquote health food like fish may actually increase this metabolite, which is really interesting.
Interesting, huh?
Yeah.
And carnitine.
Right. Yeah.
I don't know much about it, but it's so fascinating.
It's kind of the new kid on the block. Jeff Leach, who is the founder of the humanfoodproject.com, he's done a lot of research in the microbiome space, working with Rob Knight at UCSD. And so they found higher levels in meat eaters compared to vegetarians.
Mm-hmm.
And they did like a crossover study. So they gave the vegetarians meat and so forth. So yeah, it's kind of interesting. But I know I think Cleveland now has the assay. So if people are listening. But
I think they do. And Mark was talking about that because he changed his supplement regimen based on his TMAO level, which was sort of interesting.
Yeah. So have you tested yours yet at this point?
I literally just learned about it on Tuesday.
Yeah.
And then I read that study the next day, and I was like, wow, I wonder if Mike knows because you're a microbiome guy.
Sure. Yeah, it's kind of interesting.
Yeah.
Well, two human clinicals so far. But it's really interesting, I guess, like, you know, we've talked about this before, like sometimes a biomarker, if it's high, like, I want you to articulate it because I'm going to screw this up. But you said that's just a risk factor. That's not really indicative of disease.
Yes, that's a really important thing to get. So sometimes my patients will come in and they look at their labs, and the labs I use put colors on things, and they add up their reds or they add up their greens. And I'm like, it doesn't work that way, right? So this is more important than this. And we have to be thinking about these things. It's not additive, right? So I don't know. It's interesting. Like, is TMAO high in the meat eaters or fish eaters if they also ate a ton of really healthy fiber?
Right.
So food combining is always interesting. Right? It's very easy to give rats a bunch of saturated fat and say,
see, fat causes dysbiosis.
Yeah. Right.
Yeah.
So I don't know. I don't know anything about that, but it's an interesting marker.
Right. Yeah. So these studies, like you said, I mean, if they give people fish or isolated meat or whatever, but I mean, who just eats, I mean, I guess some Americans do, but if you have polyphenols with that or a little red wine or something in the context of a healthy diet.
Yes.
So that's kind of interesting.
And then maybe even how the food's prepared. Right? So did you create polycyclic aromatic hydrocarbons by the way you cook the meat, or did you create, you know, advanced glycosylated end products by the way you cooked it? Like,
or did you chew your food, or did you have hydrochloric acid
suppressed? Did you chew your food? Yes.
So many
these
aspects.
are good questions. Yeah.
So let's kind of transition a little bit to the brain. I think a lot of people, as they hit 40s and so forth, or even earlier, are concerned about cognition and cognitive function. And really, I mean, the ability to work and have a conversation and remember things is top of mind for people. So walk us through kind of where do you start looking at assessing cognitive function in your clients?
That's a great question. Well, I wish more people cared about their brain, to be honest with you. I sometimes get frustrated. When I introduced neurocognitive testing to my practice several years ago, I had a lot of pushback from patients and their doctors. There's nothing you can do. If you get dementia and Alzheimer's, there's no treatment, that kind of mindset. And that's just a bunch of hooey. Yeah. It's not true. In fact, there's some researchers that say we can see evidence of changes in cognition 30 to 40 years before dementia is diagnosed. Why wouldn't it be like any other disease where if we treat it upstream, we're going to get a lot better results? So, you know how Daniel Amen makes his career out of trying to get people to fall in love with their brain. That's the first thing he says is fall in love with your brain, which is why the SPECT scan can actually be interesting. When you see your brain, it is an unbelievable sight when you look at that. Now, obviously, you're not seeing your brain, you're seeing imagery, but still, it's pretty amazing. If you see scalloping and you're like, that's what all the alcohol's doing to my brain? Or you see that you have a big dent in your frontal lobe. You're like, oh my God, that head injury actually made an impact, and it's not a literal dent, but it's the blood flow. So first thing is, I want more people to care about their brain and fall in love with their brain and know that they can prevent dementia. There are things that you can do. So I just got back from doing a training with Dale Bredesen. Do you know him, the researcher?
No, I don't know. Yeah.
So he's a researcher. Right now he's at the Buck Institute for Research on Aging, which is just outside of Napa area. And he has published in 2014 a protocol, and it was essentially case histories showing a protocol that actually reversed early Alzheimer's and cognitive decline, including one patient who had volumetric changes in the hippocampus.
Wow.
Yeah. So when you actually see the brain change, besides just the scores on cognitive testing or neuropsych testing, it's pretty impressive. And then he published a paper in 2015 and 2016, and now he's teaching. But essentially, his protocol has, like 36 different elements to it. I think what's really important about his approach is that he's identified different types of Alzheimer's and cognitive decline. So somebody can have an inflammatory type of Alzheimer's. They could have Alzheimer's that's from insulin resistance and hyperglycemia and inflammation. They could have dementia or Alzheimer's that's from toxic influences, including, mycotoxins.
Wow. Not
just the toxins that we would assume, like mercury and heavy metals. So I think he's changing the landscape and at least opening up the conversation that this isn't a death sentence, because a lot of patients are afraid to do cognitive function testing. That is the biggest concern that my patients have. I don't want to take that test. You're just going to tell me I'm going to get dementia. You cannot tell somebody that from neuropsych or cognitive function testing alone. You can tell them they're at risk. I'm concerned. For example, I just had a new patient the other day who's a judge. So she's a very high functioning individual. She's exceptionally disciplined with her diet, her exercise. She's a personal trainer. I mean, amazing woman, what she's accomplished. And she scored average on her cognitive function testing. And as she was talking to me, she would search for words. I could tell, but she was very good at it, so she could overcompensate. And, I asked her some questions about maybe losing things or losing track of things. And so it became apparent that she was struggling in her brain. And when I asked her about it, and she kind of, well, I really don't think it's a big deal. And I pointed out in the ways that I do actually think she's already showing signs of this and we could do additional testing. Finally, she said, you're right. I don't even really want to go there. And I'm like, well, you need to go there because this is your most valuable asset. Look at what you've done with it in your life. And you're only 60. And you don't want to be in a home when you're 80.
Right.
And I mean, what a gift for somebody to say, you're a father. I'm going to take care of my brain so that Inez doesn't have to take care of me.
Oh, absolutely.
That's why I think people really should embrace vibrant health and do what it takes to get there, not just for themselves to enjoy their life, but also to not have to push that off on whoever's going to have to take care of you. So I want people to fall in love with their brain. I want them to let me assess them and talk to them about what they can do, right?
Right. And I think your approach is really important for people to kind of understand and conceptualize, because I think there's, as you mentioned, and this may be a fear, and correct me if I'm wrong, but there's this learned helplessness.
Absolutely.
Because people feel that it's predetermined, and if it's predetermined, then you can't do anything about it, so that you don't want to know. But what we're saying is, it's not predetermined.
That's
this is a
right.
metabolic, environmental, toxicant, inflammatory disease. There's different subtypes, and we now know that lifestyle-based medicine improves various components of that, which is really exciting, right? So
yes,
that's
and we can measure it.
Right.
And that's why I love Dale, because he's published it.
Yeah.
And not only can we prevent it, but we can do something about it if it's already happened. Yeah. So the mindset that the learned helplessness comes from the conventional dysfunctional model of medicine, which is if a drug won't fix it, it's not fixable. There will never be a drug that fixes Alzheimer's, period. Why are we dumping billions of dollars into something that will never happen? If you look at the changes in the brain of somebody with advanced Alzheimer's, that you cannot fix that. Right. Can you take somebody with early mild cognitive impairment or Alzheimer's? Yes. Right?
That's fascinating. Yeah.
Yeah, and you can even start with Inez's age and teach her about food choices or exercise, or perhaps even protecting her brain, not going on roller coasters, not doing certain sports where she's putting her brain at risk.
Yeah.
Right? So trauma increases dementia risk. So my friend Ed Lee wrote this great book. Everyone should know about this book. Have you seen his book?
No, tell me more.
Before you leave, I will give you a copy of it. I will give you my only copy.
No. Okay.
I will. I want you to read it to Inez. So he wrote, his first book was all about the heart for children, and this book is all about the brain.
Cool.
And it's for kids. It's beautiful. Start there.
Yeah.
Yeah.
So I have a personal, I don't want to say a qualm. I struggle with this personally because I love watching football, but what I know about the brain and cognition and CTE, it's really troubling.
That's right.
How do you deal with it? Because I know Daniel
Stop it.
Okay.
Football is horrible.
Yeah.
It's horrible. First of all, the amount of money that's dumped into one football game, could we apply that to healthcare? Real healthcare? No. I mean, if you want to get me on a soapbox, there's no place for football. I can't even have it on in a room.
Yeah.
It's disgusting. And when people let their kids play football, I actually think it's a type of child abuse because those kids have no say in what happens to their brain when they're older.
Right.
So,
And we know it starts early. These changes.
Starts early.
Yeah.
And, you saw concussion, so yeah.
Okay. Other sports, so roller coasters. I used to race bikes as a kid, hit my head a lot. I mean, what other sports for people listening right now should they kind of steer their kid in a different?
I'm conservative.
Yeah.
I mean, my husband loves roller coasters. I refuse to go on them. I'm like, you can get a coup contra coup injury every time you get whiplash. And I'm like, I already did too many drugs when I was in college. I hurt my brain. I'm not going to continue to hurt my brain. So I don't have kids, so it's hard for me to answer that. But the brain is like the consistency of soft tofu or butter at room temperature. The skull is really hard and has lots of pokey ridges. Think about it. If you let your kid do things where their head can get hit, they can end up with brain injuries. Now, the beautiful thing about a very young brain is that it's very plastic. It can repair itself much easier than an older brain. But you want to let a kid play, of course.
Sure.
But, what's wrong with, swimming, walking, running? I mean, rollerblading, baseball. There's not a lot of head injuries in baseball, right?
If a pitcher hits.
But you're wearing a helmet, aren't you, in baseball?
Yeah, and it's a real, I think, one-off situation that you would actually have a closed head injury.
Okay, so baseball seems okay.
Yeah, interesting.
Yeah,
So
but I'm conservative that way.
Yeah, I played football too, so I like watching it, but now what I know, and speaking with you over the years, I really have come to, I'm skeptical, I should say, or not skeptical, but a little bit more vigilant about how much enthusiasm I put into it, so that's interesting.
I liked Big Macs as a kid.
Oh yeah, right?
You'd never get me to eat a Big Mac.
Yeah, things have to change.
Yeah.
Assessment. Let's kind of finish off with, you have these patients that...
Brain assessment?
Yeah.
So we use CNS Vital Signs for their cognitive testing, mainly because it's validated, it's easy for the patient to do, I can track them that way. I have pretty detailed questionnaires that we are lucky enough to be using from Daniel Amen, so that's all part of their assessment when they come in. If I'm concerned and I need to send somebody for imaging, I'll send them for a SPECT scan. Interestingly, the SPECT scan apparently changes in blood flow is the very first thing you'll see in terms of brain imaging and eventual mild cognitive impairment or Alzheimer's. So that you can do functional MRI or volumetric testing of the hippocampus, but that gets expensive. And I've seen people completely transform their brain.
Wow.
And I get very excited about that. Yeah. Like cardiovascular risk factors, that's awesome to see people change. I love seeing them change their brain.
Right.
I guess just because your brain is who you are. Like you are your brain. And anybody who has known somebody who has lost their brain, has gone through dementia with somebody, it's devastating and it's tragic and it takes a long time to kill you. I mean, I have patients right now whose parents are in assisted living centers who I'm concerned about them, right, already. Like, you do realize your mom was where you are now, or your dad. So we put a lot of emphasis on that,
Right.
I want more people to put emphasis on it.
Yeah. So the SPECT scan, it's around $3,500, right?
Yeah, at Dr. Amen's clinic, they charge $3,600. It's actually a 2-day scan. So they scan you one day, and then the next day you'll actually get you'll do a CPT test to actually test for low frontal lobe activity,
Wow.
and do another scan.
And is there any, I know that like CT and so forth, a lot of radiation. Is the SPECT scan pretty low radiation?
No, no.
Okay.
Well, you are getting contrast, IV solution that is radioactive, so I shouldn't say no. Yeah,
Right.
there is.
But you would do that like once every few years after someone, we'll talk about treatment
Yeah,
in
if
a
I'm
minute.
concerned about somebody, or if they have the finances to do it, you bet. And I think Dr. Raymond's clinic does a great, thorough history assessment recommendations. They're very holistic, so they're looking at all the different factors that are affecting that brain. So they're looking at hormones, they're looking at, diet, they're looking at lifestyle. So I really like that clinic.
Yeah.
And then they're looking at, the different area of the brain that are over or under functioning. Now, I use his questionnaires, which correlate very well with the scans. So a lot of times, based on the questionnaires alone and really just spending enough time with the patient and doing a thorough history, I can figure out what areas are over or under functioning, which helps with treatment. So, there are several different types of ADD and depression. It's not one disease, and so people will respond differently to different treatments.
Interesting. But the power of the scan is just to like have that visualization, like you said, to make people fall in love with their brain.
Dr. Raymond is pretty fond of saying psychiatrists are the only ones that don't look at the organ they're treating.
Right.
They don't look under the hood. I cannot tell you how many patients will come in and they are hypothyroid, or they have low B12, or their homocysteine's high. I just had a patient the other day. This is a great example. I want to say he's in his young 60s. Hadn't gotten out of bed in weeks. Severe depression. Severe, like can't get out of bed type depression, except for he could get up once a day to go have wine because he loved wine. He was so afraid I was going to tell him he couldn't have wine. I mean, very little quality of life. And this is a guy who worked his whole life. He worked for the railroads in Kansas. And what a great guy. Salt of the earth, showed up for work, smoked, was around all the toxins in the railroad, right? Severe back pain. Eventually, he left the railroad because of the back pain, which was occupationally induced. And ended up essentially disabled. His quality of life was so poor, and he really didn't think we could do much. He was sort of like, I've been on every antidepressant under the sun. His B12 was 200. His testosterone was in the 200s, which are both extremely low.
Right.
He was severely hypothyroid. His TSH was over 10. He's nutrient deficient, and it's one of the few times that I actually feel angry, because this is a guy who has lost a couple of decades of his life. And he already feels so much better. I'm like, how can you overcome that? This is not a Prozac, Lexapro, Cymbalta, fill in the blank deficiency. And I said, you mean to tell me no psychiatrist has ever done any lab work on you? They've never looked at your thyroid, your B12 level? I mean,
yeah, come on.
This is not woo-woo medicine. This is like, doesn't it make sense? So, and that would be an area I would say, God, if he had gone to Amen's clinic, gotten his brain scanned, and actually had some testing,
Right, and worked with a practitioner like you. And going back a little bit to that Buck Institute, I think you mentioned there was like a 36-point protocol, and we were talking offline. You're doing 34 of the 36 already.
Yeah, we do. Yeah, we do a
cool.
lot of it already. So the training was confirmatory and helpful. There are docs from all over the world there. It was great. It was a great environment to be around other people who are optimistic and proactive about brain health. Yeah. And we already do a lot of it, but most functional medicine practitioners, if they know enough and they know about hormones, they're also doing that.
Sure.
Yeah. If they're treating the cause and they're committed to that.
Right. So, Kath, really enjoyed this conversation. You shared so many nuggets here. We have a few final questions, and they're a little bit more personal. We want to get to know you as a person and practitioner. I already know the answer a little bit to this question. Your morning routine. We know that successful people that are go-getters, have a morning routine. And
I'm not a morning person. Do you think it's possible to become a morning person? Because I was in therapy for years over this.
I don't know. I don't know if you can change your chronotype. You'd have to try, but carry on. Yeah.
But I'm not a morning person. So Daniel would bring me my espresso and sets it next to the bed so that I can get out of bed. And my morning routine is I get up. 2 days a week I go to spin class, and so 7 a.m. That's very early for me. I'm not a morning exerciser. I actually exercise at the end of the day to empty my bucket. And then I usually check patient messages, which I probably shouldn't do in bed, but I do. I usually read something So, some sort of science article, or I have so many notes on my phone, so I like to kind of review all my notes. I listen to a lot of podcasts.
Cool.
And then I come to work.
Yeah.
So it's not that exciting.
And you do heart math too. What time of the day have you found that to be most effective?
I do heart math before I see patients. So, part of my personal work is to not let my my dysfunction, what I'm working on in my life, enter into the conversation. And of course, one cannot help that. But so I try to sort of clean out my energy that way and come to a centered place. And I especially will do it if the previous patient, it's been very difficult, or because I feel like one thing patients never think about is I've just seen 12 people right before them, but they deserve a fresh,
blank
space.
slate. Yeah.
Yeah. So heart math really helps me shift it, and I can do it in 2 minutes.
Wow.
So I can do a 2-minute heart math and I feel completely different, and now I'm ready,
Yeah. No, just curious, because a lot of folks that listen to the podcast, we've turned them on to heart math over the years.
Oh, yeah?
Does your coherence score go up to 11 in that 2 minutes, or how does that? Because you're doing so many different. I'm just curious because
my coherence is very interesting. I wish it were better. Yeah. It really depends. I'm more sensitive to my environment than I want to admit, and my stress level. But sometimes it's very easy to get into a coherent state. Sometimes I'm struggling.
Yeah.
Have you ever noticed that?
Big time, yeah. Actually, but being in a state of nutritional ketosis, I'm always more coherent.
Is that right?
Yeah, so that's what really got me kind of convinced that there's more to the ketogenic diet besides just cutting out carbs and so forth. So it's really interesting because...
So preventing any blood sugar dysregulation that could be, who knows, increasing adrenal output so that you sustain blood sugar. That makes sense.
Yeah, so that was curious. And then the beta-hydroxybutyrate, the main ketone body, affects genetic signaling, and it may affect sympathetic tone in a certain way. So there's a lot going on there, so I would experiment with that. If folks are listening, give that a try. But let's talk about nutritional supplements now. One thing we like to tease out from every guest on the show is their favorite herb, nutrient, botanical, or whole food.
Okay.
So vitamin D, omega-3s are covered.
Yep.
You're stranded on an island. You can only take one thing, maybe two things. What would it be and why?
Well, I would take CoQ10. I would take CoQ10. I would do two things. I would practice calorie restriction. So I don't eat from dinner until usually 10 to 11 in the morning. Mainly because calorie restriction is the only intervention that has ever been shown to extend lifespan, period. And there's a 20-year monkey study out now that confirms this. So I actually think there's a lot going on with that we're just starting to understand. So I have trained myself. I don't eat after dinner, and I don't eat until usually 10 or 11, sometimes up to 1 p.m. the next day, unless I'm hungry.
Yeah.
Which I think is, a big problem with Americans, like they eat when they're not hungry. But so I would do that. And then I'm always thinking about mitochondrial biogenesis and function, right? So I'm a longevity doctor. I want more mitochondria. I want them to work.
Yeah.
I exercise. I practice calorie restriction, which can help with mitochondrial biogenesis. I take resveratrol. I take quercetin. I take antioxidants, and I eat a very antioxidant-rich diet. But CoQ10 is the rate-limiting enzyme in ATP production, right? So if you want ATP, you need CoQ10. Yeah. So I would probably take that besides vitamin D and essential fatty acids. And I can only have two things?
No, it's just to try and tease out some of the high hit rate stuff. But what I like about that, Dr. Retzler, is CoQ10 is not really readable, or not easily available from food, right? Unless you're eating beef heart or lamb heart, you're not going to be getting it from broccoli and kale, right? So fascinating. Now let's go back to the time restricted, calorie restricted feeding. Do you ever do prolonged fast, like a day-long fast? Or
I don't. I used to. I did fasting for so many years when I was in school, and I just felt like I wrecked my metabolism. I suppressed my T3. I ended up gaining weight every time I did it. I don't promote fasting with my patients anymore unless it's like a very short-term fast if they're really sick. But I don't. I believe in calorie restriction in general, and then I teach my patients to eat when they're hungry. And the 3 types of hunger, are you actually hungry here, like I am right now? Are you hungry here because food tastes good and you want to keep eating? Or are you hungry here because you're, psychologically or emotionally something's going on?
Yeah.
Yeah, and so I think Americans are trained by their personal trainers or whomever, they've been told that they need to eat every 2 hours. to induce endotoxemia. I don't know why they need to eat every 2 to 3 hours. If they're not hungry, they're eating by this, which is why they end up gaining weight instead of eating, when you're really hungry, eat.
Mm-hmm.
When
It's
you're
beautiful.
not hungry, stop. It's
Pretty simple.
not that hard. Yeah.
Yeah. But if you don't do calorie restriction sometimes, you don't really feel what that real hunger is.
You absolutely don't. You're absolutely, I can't,
So-
patients all the time say, I don't even really get hungry. I'm like, right, that's
Yeah.
the problem. Like,
Skip
yes.
dinner one night and then...
Trust me, you will be hungry.
Yeah. Oh my goodness, that's
Yeah.
beautiful. So as a kind of final question here, if you were to bump shoulders with the President of the United States or someone from the World Health Organization and just had 30 seconds to share with them a lifestyle or health tip, what comes top of mind? Just something really powerful that you would want them to know about, possibly that they could influence policy around.
Oh, wow. It depends on who the president was.
Yeah.
But I would probably beseech them to use their power and influence to teach the American people about prevention and that they have control over their health destiny. There is so much information coming out now about genetics that people think everything is genetic, and genetics are a small part of what happens. So I would beseech them, please tell people they can be in charge of their health destiny instead of them feeling like they're at the mercy of fill in the blank pharmaceutical company or bad luck or bad genes. That would probably be it.
Love that. To empower people
Absolutely.
that day-to-day choices really matter and influence your
Yes.
health.
In real time.
Yeah.
Yes. And
Beautiful.
they can do something, right? It doesn't happen to them.
Well, in closing, Kath, I really enjoyed talking with you. I'm grateful and honored to consider you a friend, you and Daniel. I want to just mention to our listeners that you have a wonderful book out there, Hormone Synergy, which is available on Amazon.com and so forth. And if folks want to connect with you, I know you have a few different websites and so forth, and you're doing different things, coaching practitioners, like patients and practitioners. Is there one resource you want people to kind of learn from you?
Oh,
Just one-
hormonesynergy.com.
That'd be the
So
best way.
there's a lot of research on our website. And then several years ago when I gave a lecture for patients, I had it recorded and actually put it on the website. So
Oh, cool.
anybody can watch that, access that, if.
If they're interested.
Yeah.
Awesome. Well, if folks are listening in iTunes, I'll put the links to that on the show notes page over at highintensityhealth.com.
Oh, that'd be good. That'd be good.
Yeah, so Kath, keep up the great work. Thanks for coming on. I really enjoyed talking with you about all these different things, and look forward to connecting with you sometime soon.
Awesome.
Thank you.
That was fun.